Okay, so are you sure there's a leak, right? So let's make this very interactive. Let's see.
Good idea.
Okay, if I can forward this, no conflict of interest. So here we go. Start. Morbidly obese, right? Aortic stenosis, severe. Came in because of a shortness of breath, the usual. And the funny part, if you look at his weight and his height, same number, 166, right? So look at the BMI, 60.2, right? So long discussion before we schedule a plan for large bore access. So it's the usual, the fellow went get CT and everything. The sizes are good. Iliac artery is adequate, common femoral is 9.6, 8.2. So size is not an issue. The problem is the depth of the artery, right? So femoral access is adequate for large bore access, so I called my surgical colleagues right away. BMI 60.2, should we think of alternative access so that we can assure ourselves of hemostasis? Remember, in our experience with the MANTA device, anything more than 30, 40, you're going to have a failure in terms of the delivering. And then I've been asked with you per close, I don't think it's going to reach on this guy in terms of getting that femoral artery. I proposed to do ProStar, my partners said they want to use ProStar. So anyway, so here we go, right? So the plan was, okay, now so why do we do this? Let's aim to use for MANTA and just be ready on the side, and if anything goes wrong, we'll take care of the problem. So this was the arteriotomy that they took, right? If you look at it, the entry point is good, and it was just a fluorosave. It's below the inferior epigastric artery if you look at it closely, right? So other options would be, maybe I'll ask Vinky, should we do open? Make sure we can close it nicely.
I can fix anything, so I would do it percutaneous, yeah.
You won't do open?
No.
Our surgeon said no go because they said, yeah, you will success with TAVR, but then our groin's going to be an issue after the procedure. Yeah, that's the problem. Okay. Then, of course, like I said, I proposed widening ProGuide ProStar, but they decided to go MANTA. So I said, okay, play the game. So 16 French sheet, they put it at 20 gradient. Look at that aortic, you see the gradient after the TAVR, beautiful gradients down to 0, right? So time to take out the large sheet now, right? So I said, you know, why don't we prophylactically put the crossover sheet, be ready, put the wire down, pull out. If anything goes wrong, we'll take over the management of the patient, right?
What size sheet is that, up and over?
An 8 French, 8 French, okay?
What's the largest covered stent you can deliver through an 8 French?
If you do a balloon expandable, you can put the balloon expandable one.
Because most of the time when you rupture the external.
Yeah, but cover stent, you're right. You have to go to an 11 French sheet to deliver.
So what you're thinking and what you're preparing for is to place a covered stent.
With VBX, well, 11 by 59, 11 by 79 is 8 French now.
Yes, it will.
VBX2, and you
Yeah,
can
it will
take it to 16.
It will take, yeah.
Yeah.
But the question is, are you willing to put the balloon expandable across the femoral head? Me, I'm not. I know a lot, there are papers published on that, and actually in the DC area, there's a couple of vascular surgeons willing to put it in, but so far I've not fallen into the trap. Okay,
Okay, show us the
okay,
shot.
let's go. So the bailout plan, then if it doesn't work, we'll put a covered stent, right? That was the plan. So of course, MANTA, where they put it in, anyway, didn't go wrong, didn't do right. So put in the big shit, and then I was there just at the control room. So
Play that again.
Huh?
Play that again.
Yeah, it's playing.
So is that a high takeoff of the profunda and the junction?
No,
that's the internal.
no. It's high.
Okay, good.
But you can see the inferior epigastric artery there, right? Okay. So it didn't work, so I came in, and we have the 8 French sheets. So all I have to do is basically continue with the plan. We already had the EPTFE stent at the bedside, ready to go. Okay. So time to treat, right? Forgot, I don't know if you said R, right? You already got dented bowel, so that means, a urinary bladder, so that means there's RP bleed now, right? That's clearly a sign of an RP bleed, right? So
you used the MANTA device.
Yeah.
The MANTA did not work.
They didn't go in, the sheet didn't go in, so they aborted, then they put in the old sheet back.
So
you
tell
didn't
me
lose
again,
wire after the MANTA.
It wouldn't go with the sheet? I'm sorry.
So they tried to put the Manta sheet. Remember, the Manta comes with its sheet for delivery.
Yeah.
It just won't go in. He just
Okay.
had difficulty.
So you have your wires still there?
The wire was still there. So they aborted and put in
The bigger sheath.
put in the back. So the sheet, the 18 French sheet, and I was there at the outside then. Okay. So just to show you that there's already RP bleed going on, right? You see the blood is already dented to the side.
Yep.
Okay, so here comes my first problem, and actually you brought it up a while ago, right? So we took a picture. I mean, I can take a picture of it so you know where the landing zone is, and everything's ready to go, right? So I chose that I need to use an 11 by 50 Viaban, right? And basically, this needs a large bore access, right? It won't go through an 8 French sheet. So the first question I have to ask is, actually I already answered by that time, is should you use a balloon expandable, as Dr. Suggested, and just put it in and cover that common femoral artery? Would you guys do that?
Did you call the surgeon by this time?
Oh yeah, they were aware of all this plan now.
Were they in the room?
On,
Or on the golf course like I
No, actually, before we did the case, Vinky, we talked, and they know about the patient. They said, no way we're going to do surgery. When this happened, we call them. I mean, every time we have a bleed, we call them, and they would just say, do whatever, they not call
Because I
us
just
back.
did one last week, and we can talk about it too. But
So would you put a balloon expander? What's the first question?
You could put balloon expandable, but then you put a bare metal stent in there to just make it be like a self-expanding stent, if you have to.
Yeah.
It's not ideal, but if you have to.
Yeah, I wouldn't.
I wouldn't.
Because upsizing is pretty easy to do. You can occlude the artery with the balloon through the big sheath that you have, and, you still have.
if you have control, if you
Yeah.
have control from the IPSI
Yeah.
side, either with your sheath or with your balloon,
Yeah.
then upsize. Yeah.
Upsize. So everybody agrees, no balloon expandable, right?
Wouldn't be my first choice, let's put it there. But in an emergency, anything goes. So
This one was stable because remember, I know she had the RP bleed, but we had the big sheet in, so he's controlled right now, right? So I was at Wheeling, so like I said, our option is put an 11 French sheet and deliver the 11 EPTFE stent, and then I'll share with you. So I have this technique what I call the bareback technique, right? We wrote about this a couple of years ago. So basically bareback, no sheet. Advance the Viaban sheetless through the arteriotomy site. Then after you do it, when you pull out the Viaban catheter, just put back the 8 French sheet and you get good hemostasis.
and then you fix the other side.
Yeah, then you just close it with a angioseal or perclose, whatever you want. So that's what I've been doing. So bareback technique. So that was the plan. So bareback technique. The key thing about bareback is put a very supportive wire around it, right? That means to say, I put the supracore wire all the way down to the popliteal on the other side, right? So that means say, chances of losing that wire is like 0. Then the second thing is you have to prep that groin. And I do is I cut and I basically create a big path to the arteriotomy site, right? That means say you won't get caught on anything. Then the key thing is when you advance this, you have to follow the, right? We've done about 50, 60 of this now, and only one time I aborted because when it hit the common iliac artery, I felt resistance. I don't push, I pulled it back and then just put in an 11 French sheet if you need to, right? So with this, we haven't lost a stent. So we did this, right? Wow. It went, ready. Then all I have to do is basically pull a sheet, deploy the Viaban, right? High fives, right? Beautiful. The left groin is an 8 French sheet. I can close with an angioseal or a perclose and be done with, right? Did I get the perfect result?
What is your DSA picture? Why you were not doing the SA?
DSA was okay.
Was okay, the SA?
Yeah. We didn't see anything.
I just think you need to look up at the upper part of that
Did
iliac.
you balloon this afterwards?
But yeah, it looks,
Oh yeah, I do. I post deal every time.
I mean, otherwise it looks okay.
Yeah, otherwise it looks okay, right?
I would pull your sheet back and shoot.
Yeah,
So anyway, so it looks okay, right?
yep.
So the procedure took about 5 minutes, but at that time, so my rule in the lab is when you have CHAPI, just give the blood. We don't wait for the H&H. Got 3 units of blood, stable. Went back to the ICU. Everybody was happy, right? 6 hours, very labile. Blood pressures up and down. Receive another 5 units of blood, and they had to go 2 platelets of unit of platelets. What would you do? We look at, I'll show you, we did the angio.
CT?
There's your angio, the digital angio.
I'm sorry, that's the angio.
Yeah, this angio, the digital one. With pulled
So
out.
you went back to the cath lab and shot an angio?
No, we have to make a decision at the time.
Oh,
So-
you're making a
Yeah,
decision.
so that was the angio after the procedure, right? The angio after the procedure, the digital DSA. As you do.
I mean, it depends on what's more readily available, either an ultrasound or a CT.
CT.
Is what I,
Okay, good. So this happened around 10 or 9 or in the evening, and you know how staff these days, any bleed, get a CT scan, right? So they went ahead right away to the CT scan, right? And then this is your iliac, right? It's pretty good. This is my 2 cents. But sometimes our residents would order a CT scan without contrast, and I said, what are we looking for, right? So this is with contrast. And then, of course, here's the film from, boom. Is there a bleed?
There's a hematoma.
No? So actually what has happened, I was driving in because the resident told me they were sending the patient a CT scan, so the radiologist called me and said, Nelson, there's a big RP bleed, and there's active bleeding from the stent that you put in. And true enough, if you look at the CT scan, you can see that basically the viaband, and you see contrast.
yeah, but you don't know if that contrast is new or old. I mean, that could be contrast that was from the time that you placed the stent even.
But then this is a time when he was hypotensed and everything, so this had to be an active bleed. Has to be an-
This is why duplex is better.
yeah. We could yeah. So my question to you mean there is a leak? And they said, yeah, there's a leak, there's bleeding. Then I said, we put in a covered stent. I'm getting a type 1 leak. It's hard to believe there's a type 3 leak, right? Hard to believe, right? And we have an angio just 2, 3, 4 hours ago that showed it's A-OK. So I said, okay, I have no choice but to bring the patient. I was driving in at the time, just bring the patient to the cath lab. So patient, right? So what should we do? So I made a decision, back to the lab, right? And of course, BMI of 60, I said, let's go left radial. So this is the review of the angio that we did during the procedure, right? To the left is the arteriotomy site that we did, and you can see the entry is good. If you can see the inferior gastric artery there, and this is the final angio of the deployment EPTFE. Nothing, looks pretty good, right? Okay. So I brought him to the cath lab. So the question is, where's the source of the bleed? So I'm looking basically for a type 1 leak or a type 3 leak, right? The only possibility.
Why do you say it's a type 3?
I'm just saying because they said the leak is through the stent.
It's not type 3. Type 3 is a separation of 2 stents.
Oh, yeah,
It's only one stent.
or you have a, what do you
Material
call-
perforation.
Or a hole in the
Oh, a
stent.
hole
One
in the
bareback.
stent.
Or a hole in the stent.
Yes.
Yeah.
I know, unlikely, right?
Unlikely.
That's what
Unlikely,
he's saying.
but that's what the radiologist kept on telling me. Okay, that's fine. So I accessed from the left radial, put a 5 French sheet, put a 5 French pigtail, then took a shot. See anything? Not really. So time to go selective. So I put a 5 shuttle all the way down to the right inflammar, then put 125 cm vertebral. Remember, on a CT scan, we know where the bleed is, right? It's where I implanted the stent. So all I have to do is just put a catheter there, and this is it, right? This is it. So I injected selectively, basically, into the right iliofemoral segment. Right, there you go. Okay, I'll just go faster, we're running out of time. Then that was AP.
I was going to say, the problem is from the CT, it should be right where you,
You need an angled
Yeah.
view.
yeah.
Yeah, so the left femoral is good because that's what, but although the IR was very sure that it bleeds on the right side, left is clean. So this is, the AP didn't show anything. This is on our RAO 30. Then we see something.
There's a retrograde flow through that branch that,
Coming out the back wall.
There's double
there it is.
density.
yeah,
Yeah.
yeah.
Yeah, I prepared this, so, okay, right? So here we go. If you look at this, right, there's your bleed. delayed, right? Actually, it's retrograde. It's not from the femoral artery. It's retrograde bleed.
I'm still not even sure it's a bleed, Nelson.
It is.
Looks like a
but remember, you have a CT scan that shows a big RP bleed. You have a
But
contrast.
you had a big RP bleed before you left the lab.
Yeah, could be, but it's bigger, and the H&H dropped 5 more units of blood. And then I'll show you. Hold on. So, okay. I don't think he's pissed off at a type 3 leak, right? So I was preparing what I'm going to do, or actually tell the truth. I put it up. I called a vascular surgical friend. I called a couple of IR and see what they think and what we should do. So I put in the balloon just hoping it was a type 1A, whatever, and hoping for a fix, which I know is not going to happen, right?
Unlikely.
So post-balloon occlusion, nothing changed. You can still see the leak, right? Watch it. Only the area. Here it comes. There it is. So it's coming from the hypogastric, right? Right? So basically, look at the picture, right? So the question at that time is treatment option is, we don't know, right? Basically, it's a type 2 leak, basically from the corona mortis, from the hypogastric artery, right? That feeds also the inferior pregastric artery, right? So basically, that's the source of the leak.
So
Yeah.
the thing is, you did not have an angiogram showing exactly where the leak was, because what you did was you pulled the sheath and you put the covered stent. You did not know there were any branches you covered that can have a retrograde behind the stent.
Yeah, the only vessel there would be the inferior pregastric
Epigastric.
artery. Yeah.
So are you saying the mechanism here is that the stent is not fully closed to the femoral artery?
No.
And it's leaking around it?
Most probably, the inferior epigastric artery was hit
There's got to be a
With your
tear.
access?
A tear in there.
during the
yes.
access, was hit, right? So it's a retrograde bleed.
I mean, it's like when you rupture the iliac and you cover across the internal, and then there's retrograde bleeding coming from the internal, even though you've sort of covered the whole external bleed.
Yeah. So here we go.
coil
So basically, type 2 leak, we have to occlude the inferior pregastric or the corona mortis branch of the vessel. So the question is, this, I think you guys know this, right? So basically, embolize it, right? I can use whatever available in your hospital. And this makes sense, right? It's basically a valve, that's why you have the RP bleed through the corona mortis, right? The question, how do I access the vessel?
Well, you said it's coming through the internal.
Yeah, right? So I called an IR guy, said, and also the best way is to go to the hypogastric, find it, then retrograde up into the corona mortis. You can say right superior epigastric, but that's, I'm not going to do that, right? So basically, hypogastric artery is the best option. Or, and I said, I'm not going to do that. I'm coming from the left radial. I don't have enough length of anything. Patient is so big, it's just so hard to find the artery. So I said, I'm going to do direct access because I said I can get it, right? What I mean direct access is I'm going to do it through the Viaband stent. Okay. Remember, the Viaband stent was just deployed 6, 7, 8 hours ago, so it's not endothelialized. So I can go behind it, right? So what I did was I got the Command 18 wire, put a nice CTO bend and a J. Then I was able to insinuate with the support catheter behind the, the Viaband stent. And you can see it there, right? It's in video, so you should see it going up. Then once I get it, remember, I had my angle 30 REO. Then all I had to do is basically place it in the right position. Then I inject it selectively, and you can see the inferior pregastric artery corona mortis being filled, right? So the question right now, the fellow was asking, so Dr. Brown, how are we going to seal this off? So we wrote about this a couple of years ago, right? So that's it. So to answer that, right? So I did the thrombin blood patch technique, right? So basically, thrombin blood patch, I'll show you. Then after that, just occlude it. So thrombin blood patch, nothing more than I get patient's blood, about 2 cc of the patient's blood. Then I mix thrombin, about 1,000, 2,000 thrombin. As it becomes to gel, you get a 2 cc, a 3 cc syringe, get it. And remember, I'm not injecting thrombin, I'm injecting like a blood clot, right? And that's what you see, right? It's a piece of clot. Then I just inject it through it. I'm not worried about anything. Remember, this patient already had the RP bleed, so I just filled up that site, and then This was after. And we sealed off the endo leak, and he did well. And true enough, it was really on that source. And groin looks very good, actually, even the following day. But, oh, my God, his scrotum was so big, the perineum to the scrotum. Basically, from that tract, right, from the hypogastric to the coram mortis, is basically just slick through that and a big RP bleed. Unfortunately, he had AKI, so we dialyzed him for a day or two. Then he did well, actually discharged him. I follow him in clinic just for a follow-up, and he's doing fine. Renal function is back to baseline.
That's good.
Just a very unusual bleed, and like I was telling the fellow when we were done, lesson learned is basically sometimes you have to think outside the box.
Would you have done anything different?
Not really.
Yeah.
Yeah. So I think the lesson here is, like I was telling the fellow, is access. It would have been nice when they did the access, you take a nice angio of the access site. They just did the floor to run, and we presume we saw it.
Picture of the access.
Oh yeah,
First picture.
it's not
Did you
perfect.
see?
Yeah, it's not perfect.
Okay.
Can you bring it back?
Why didn't you use a coil? I didn't understand why you didn't just put a coil there.
Coil. I have an 018 support catheter. You will have to deliver the coil, but it's very difficult to do that, right? You need an 017 lumen, and then where you find the vessel. With the thrombin blood patch, you just pick a big clot into the system, clutch it off. Yeah, I do this all the time for. Now let's go back to the first.
Original.
The original. I think slide number 1, number 2, please. Yeah, I'll forward it here. Here. So this was my criticism at the time that, we took this, they just floor saved it, didn't take a real nice angio, we can see, but I'm sure this is where we hit the inferior epigastric artery.
Yeah, we've had this happen a couple
Yeah.
of times on peripheral interventions where they continue to bleed after successful treatment of the access site, and you either go through it, like through and through,
Yeah, yeah.
or you catch it at the right at its junction. And
Actually, one case done is right through the vein to the artery.
Yeah, yeah.
And then we forgot about the vein. The vein continued bleeding. Unfortunately, it caused an RP bleed. Okay.
So
Thank you, Nelson.
one question I have is, he obviously was a high-risk femoral access patient. Why not consider an alternative option for the TAVR, like a cut down on the carotid?
It could be. I mean, this guy, most probably, if we're going to do alternative for this that we discussed, we can do transcaval, right? Transcaval doable on him, although it's
Still big.
so huge. It's big.
I mean, if his
Or
BMI is 60,
subclavian.
Subclavian, sure.
access to the carotid is
Even
not
then it'd be
simple
bad.
there. Amazing either, right?
Yeah.
If his BMI is 60, the access to the
His
carotid
neck
is not
is- neck is
quite
like
that
this,
easy
bro.
either.
It depends if he's centrally obese,
No, he's
or if he's low.
What kind of obesity was
he's
Five-
total obesity.
Yeah,
Five,
but
and
the other comment
360.
is I want to come and work in your hospital because there's no way at my hospital I get to sleep through that case happening. No way. So bravo. I mean, you did a good job.
No, we knew the resident fellows, they call right away.
Yeah.
Yeah.
Another option would be, looking at the whole case, these people who are so obese have such a large overhanging pannus, it's so difficult to, control your puncture from the right femoral. Other would be, looks like this man has fairly big size arteries. You could have gone to SFA as an approach. What do you think?
Yeah.
possible?
Option.
Okay, Nelson, thank you.
Thank you.
We beat this enough. Nice job.